Welcome to our latest episode of the Lebanese Physicians Podcast. And today we will be discussing clinical reasoning and artificial intelligence in medicine with Dr. Raja-Elie Abdulnour. Artificial intelligence is rapidly transforming healthcare, but its greatest impact may not come from replacing physicians. It may come from augmenting how clinicians think, learn, and care for patients. And that's what we'll be discussing today with Dr. Abdulnour, who is currently at the New England Journal of Medicine. Raja, welcome to the podcast.
Hi, Khalid. Thanks for having me.
Raja, before we start, can you just tell us a brief introduction about yourself and how you ended up being involved in artificial intelligence in the New England Journal of Medicine?
Sure. I'm a pulmonary and critical care physician. I practice here at the Brigham and Women's Hospital in Boston. But I'm also actually working full-time at the New England Journal of Medicine, the NEJM group. So the NEJM group is a group within the Massachusetts Medical Society who publishes the journal, the New England Journal of Medicine, and other publications. I'm also editor-in-chief of NEJM Clinician, where we survey and cover and write about published articles in NEJM and elsewhere. But before that, I was a physician scientist. I was working in the lab studying ARDS, acute respiratory distress syndrome, mouse models, human models. But I've always been interested in education, specifically using software to teach education and gamified software to teach how doctors think. Khalil, I don't know about you, but I remember in medical school, and I think we went to the same medical school, we were very book smart, right? Very book smart. We would study extensively. We would ace our our tests, our standardized tests. But I don't recall getting any formal teaching in clinical reasoning. You know, what is the mechanism of thinking? How do doctors think? How do you come up with a differential diagnosis? How do you come up with a management plan? And a lot of it was an apprenticeship. You just go into the clinic and then you learn how to think. And frankly, it's everywhere. Right? So when I then came to the States for residency and later fellowship, again, it's this abstract, quote unquote, art that is acquired by working at the bedside and learning from peers, getting feedback from peers, but nothing really formal. And then when I did the USMLE Step 3, again, I believe you and I both sat for that test. Another, multi-hour, exhausting, multiple-choice question-based exam. But there was 10 minutes in that exam where there was a clinical case simulator, where you were provided with a case and then you would ask questions and get answers back. And I was riveted. I was very engaged, and I thought that should be the way that we assess and learn clinical reasoning. And so back in 2015, I reached out there was actually a competition at the Brigham and Women's Hospital, a hackathon, and I proposed to develop a video game to teach how doctors think and how to assess clinical reasoning. And I won the hackathon. All that meant is that there was a news release internally, and the editor-in-chief of the New England Journal of Medicine learned about this idea. And then we met and discussed it further, and we built a prototype on teaching and assessing clinical reasoning. And then in 2020, I left the lab and joined the NEJM group to develop that software. I was very fortunate to be able to connect with the people that wrote the book on clinical reasoning. Education scientists, clinical reasoning researchers, including Judith Bowen, who is the author of probably one of the most read NEJM review article on clinical reasoning, but also others. And together we designed what became then NEJM Healer, which is now has been sold, but basically a virtual patient simulator that takes a student or a trainee or anyone through a case and breaks down the clinical reasoning process, which we can talk about in a minute. And so that experience, combined my expertise in research, my clinical reasoning expertise as a clinician, as an educator, and then to learn everything that needs to be learned around cognitive science and clinical reasoning, software development, structured clinical data. So a lot of different experiences. And then in November of 2022, ChatGPT sort of was made available to the public, and I started using it. And then I quickly realized that this AI tool, by the way, Khalid, I think you should put on mute because it's I'm hearing your pings.
Oh, okay. Yeah. Go ahead.
And then in November 2022, ChatGPT is made available to the public, and I started using it as a clinician, giving it some of the cases I developed for the software, and quickly realized that it was accurate and it was expressing clinical reasoning. Now remember, ChatGPT or large language models are next token predictors. They predict the next token, and in this case, words. They do it so well that they can simulate reasoning. And that got me both worried and excited at the same time. Excited because we have access to a tool that can reason or express reasoning, but worried because it's not entirely sure that it was doing it correctly. And then I teamed up with other clinician researchers who also got excited and worried. And together we were able to do some research on assessing AI's ability, large language models' ability to reason safely and accurately. I worked with Adam Rodman and others, and we published a paper that showed that ChatGPT expresses clinical reasoning in these simulated cases better than residents and clinicians. And a separate paper with Travis Zach and others showing that large language models are biased. So if we give AI a case, two versions of the same case, one version is a male, the other is a female, or one version is a white patient, the other is a black patient, we will get different results. And from there, I kept doing research on the topic to further demonstrate some of the nuances of clinical reasoning by these tools, including a recent paper we published in Science, showing that the most recent models, in fact, a model that's almost a year old now, is able to solve complex cases much better than humans alone. In fact, it's able to solve some of the complex cases in 90% of the times, whereas humans would solve them at 20 to 25% of the time, showing that these models are no longer testable or accessible with our current tools, and we need different ways to assess them. So that's it in a nutshell.
Yeah, that's very interesting. So you started off with the clinical reasoning software even before the advent of ChatGPT, and now there's an extension to ChatGPT and what it can do to us. But one thing I want to ask you, I want to understand clinical reasoning a bit. So when you watch an expert clinician evaluate a patient, what cognitive processes are occurring beneath the surface in this case?
Yeah. So there's a lot of work out there on a lot of theories on clinical reasoning. The one that's most talked about and researched about is dual process theory. Clinical reasoning starts by capturing data. So there's a very first step that's around data acquisition. And data acquisition is either answers to questions that the patient is giving, a tactile or auditory signals that you get when you're doing a physical exam or you're putting a stethoscope on the patient's chest. But there's also passive data that comes to you. For example, walking down the ward and then looking through the door and then seeing a patient in respiratory distress, right? So there's this data just coming at you all the time. And the first thing that the brain does is, from that data, is integrate that data into higher level concepts that ultimately match specific problems. So there's this inductive process where external data is acquired and transformed into a problem representation or a representation of reality. And that is a lot of this is pattern recognition. Our ability to infer problems from data is really based on our knowledge. And for example, a lay person can recognize, a mom, for example, can recognize a common cold when the child has cough, runny nose, sneezing. And an expert cardiologist can recognize AV-NRT from a history and EKG tracing. That pattern recognition is essential for clinical reasoning. And quite often it's enough, right? If you've seen 100, 1,000 cases of a STEMI, the 1,001 case that's going to present, you will be able to quickly say, I've seen this case so often, I've read about it in so many books, I've been doing this for 20 years, I can recognize the pattern of a STEMI in a patient. And that process is fast, that process is intuitive. That's what we refer to as System 1 thinking, which Daniel Kahneman in his book Thinking Fast, Thinking Slow talks about. So that's the thinking fast process. But then what happens is that sometimes you recognize the pattern, but it doesn't really fit. There's something odd about the data that you've acquired. There's something unfamiliar with the problem that you've represented from that data. And that's when the brain slows down. For example, when a surgeon is doing their 5,000 cholecystectomy and they're doing the surgery and the plane doesn't look right. And so literally the hands of the surgeon slow down. Same thing at the bedside. I'm representing a problem as I'm talking to a patient. The story doesn't really fit. So I slow down and I then take on a more of an analytical reasoning, a System 2 reasoning, which is slower. And this is where I take the problem that I've identified, and then I search for similar stories, similar scripts of patients that I've seen in my experience, and I start building a list of hypotheses. This could be a STEMI, but this could be acute pericarditis. This could be pneumonia. This could be an esophageal spasm, so on and so forth. And that's when you build a differential diagnosis. And according to your differential diagnosis, you have in your mind, you're carrying these different exemplars of diseases, these different illness scripts, which then drives you to, okay, I'm thinking about these 4 or 5 diseases. I need to go back to the patient and get data to either support some of these hypotheses or refute them. And then I iterate until I've prioritized my differential diagnosis, and then I have a top diagnosis if we're lucky.
Right. So basically, part of clinical reasoning is a lot of it is intuitive, but a lot of it also is analytical, right? So can it be taught? Because I know we do the medical student courses, and sometimes we teach them how to create illness scripts and all this stuff, or is it mostly through experience, gained through experience?
It's a little bit of both. There is the way I think about teaching is actually quite similar to how, and quick disclosure, I am not a computer scientist. A lot of what I learned about artificial intelligence is through my own learning, trial and error, which was an example of how we learn. I think about learning in 2 ways. One, there is a didactic form of learning, which is in the AI world, you would call it supervised learning. And that's where you benefit from the experience of others. So other clinicians, other scientists, other experts who've downloaded, quote unquote, their information and their knowledge in textbooks and research articles, and which then I can read. And so that's learning that I'm acquiring in a supervised fashion. I trust that what I'm reading is accurate. And instead of me, every human, when they're born, having to rediscover what pneumonia is, what their STEMI is, they can actually go and read about it. And so a lot of the reading happens in that way, and sort of that's a form of didactic reading. But then, in addition, there's a lot of you complement that learning through learning by doing, and this is more of an unsupervised form of learning where you use your knowledge to derive problem representations, come up with hypotheses, and then you test them. And if you're correct and you have a good outcome, then you've learned that what you've done is correct. And if you, conversely, your actions have a negative outcome or no outcome, then you deprioritize that learning. And by doing this often, by practicing often, sometimes referred to as deliberate practice, so practice with the intent of learning, with feedback, you grow your knowledge base and you grow your fund of knowledge. So you have to have both. You have to accompany learning by doing with learning by reading. One thing you said, Khalil, which I want to push back a little bit on, is the intuitive aspect of things. Is like, what is intuition? Intuition is a form of reasoning. Intuition is where data around you is integrated by your brain and tells you there's something going on. That itself is data science. There are neurons that are reacting to data and that are signaling to your brain that something's going on. It could be pneumonia, it could be cholecystitis, so on and so forth. It is still pattern recognition. What I've been really working on is trying to dissuade or demystify the idea that clinical reasoning is an art, quote unquote, because there's some pretty good science to support what goes on in the brain of a clinician or any human when they're problem solving.
Right. I mean, exactly. And this brings me into the next discussion that we're going to have is about diagnostic errors, because like you learn about intuition, part of it is analytical, but there's still diagnostic errors are still a major cause of patient harm in hospitals. And so why do they happen? And what are the most common cognitive biases that lead clinicians to make mistakes?
Yeah. Why do they happen? The Institute of Medicine's report, which is now the Institute of Medicine became the National Academy of Medicine, published a report decades ago called "To Err is Human," really putting a spotlight on the fact that diagnostic errors are too common and very costly. And I like the title, "To Err is Human," because it tells you that it's an unavoidable fact of how we think and who we are. Based on what I've described to you on clinical reasoning, which is an inductive process, you can already see that it's a very complex process and it's a process prone to error. Our ability to recognize patterns requires us having the right data. If I don't see an EKG, I won't be able to diagnose a STEMI. If there is an EKG that I was not provided or it's lost in the chart somewhere, same thing, an error can happen. It's also dependent on our knowledge. For me to develop a pattern or to recognize a pattern in a set of data, I need to have that knowledge in my mind. And therefore, you can see that knowledge or the lack of it, or even worse, biased knowledge. So knowledge I've acquired that is either false or inaccurate or incomplete will lead me to recognize false patterns and then take me down the wrong path as I think about a patient. And then even if I have the right problem, even if I've made the right diagnosis, errors can happen if I don't communicate my diagnosis appropriately. If I don't share the diagnosis with the patient, with their family, with my teammates, with the person at the front desk who's going to order a follow-up, you can see that at each one of these steps, errors can happen. And this is only the human aspect of error. We're not even approaching at the system level of errors, where, I mean, Khalil, how often have you ordered a test that's already been done many times before, but it's just hard to get from an EHR, or a test has been done in a separate health system and it's hard for you to get? Data interpretation. Sometimes errors seep in a report of a radiologist, or the report is accurate, but its interpretation by the clinician is there are errors. I mean, I remember once reading a radiology report and I just focusing on the summary, but what the summary did not include was that the patient had chronic mesenteric ischemia, and that was further down in the report, right? So you can see how errors can happen just by human nature. So there are human factors and there are system factors, and these errors are very costly. I mean, I want your viewers and listeners to recognize that the number we're talking, like in the US alone, for example, it's estimated that around 800,000 patients either die or are permanently harmed due to reasoning error, due to diagnostic error. There's a recent study in hospitals where they looked at patients that either died or were transferred to the intensive care unit as a marker of clinical deterioration. And they looked at how often do diagnostic errors happen in these patients. And they found that almost 25%, a quarter of patients who die or are transferred to the ICU in a hospital suffered a diagnostic error. And a lot of these errors are related to assessment and to interpretation of test results.
Yeah, right. I mean, it's a big issue, and as you said, I think it's cognitive biases, assessments by the physicians, interpretation of that results, even maybe forgetting to communicate test results to the patient, such as you biopsied somebody for lung cancer and you forget to call them or hook them up with the oncologist or discuss their case at tumor boards. So this brings me into what we discussed earlier with ChatGPT and others, AI and clinical decision making. So what aspects of diagnosis is AI particularly good at?
Yeah, so what we know so far based on the research is that if you give complex cases that are more or less vetted by experts, for example, the New England Journal of Medicine publishes these very difficult clinical cases every week. If you take these cases and you give a case to a human, to a group of humans, around maybe 20 to 30% of the times a human will be able to tell you the final diagnosis just based on the case presentation alone. If you give the same cases to GPT-03, which is an older version of ChatGPT, currently ChatGPT is at 5.5, which is more powerful than the prior version, 80 to 90% of the times ChatGPT will get the right answer. So we know that if we give these tools, especially the frontier tools, the bigger tools, complex cases, they will solve them better than most humans. And that's been repeated over and over. Because these models have been trained on all of written or spoken human text and human knowledge, they're able to recognize patterns where it can be very hard for humans to do so. And again, it's all pattern recognition. So this is important, is that these AI tools, all they do is recognize a pattern, and then based on the pattern they've recognized, predict the next word. And they do this over and over, right? The AI does not stop to say, oh, wait a second, this is a pattern I don't recognize, and therefore I need to slow down and think. AI doesn't do it. AI cannot, at this stage, say, I don't know, which is something we've published recently on NEJM. And so they're very, very powerful. And so we also know that they are, so just gonna repeat this point. What we don't know yet is how good they are in the real world, right? Because in the real world, we're not solving case reports that are published in articles. We're not solving multiple choice questions. What we're solving are real patients that come in with real concerns in a real setting where data is extremely complex, data is not curated, data is not clean. And in these settings, there's some research that's starting to get published. There's a couple of articles that were published in Nature where they tested models on making diagnosis and a management based on EHR data, right? So this is, instead of giving them case vignettes, they gave them unfiltered, cleaned up to some extent, and structured EHR data, and released the AI in an EHR sandbox. And there they found that these tools were quite effective and accurate. And one of the study, which is a study published by the Google group, did like OSCEs, where they took patient actors and they had the patient actors interact with the chatbot, but they did not know if the chatbots were AI or a human physician. And then they asked the patients, and then they asked blinded physicians to assess the interaction, and the AI did better than the human physicians in all of these perspectives. So these tools are great in some ways and are getting better in others. So I wouldn't be surprised if in a few years we will have AI working alongside clinicians, helping gather information, maybe like a pre-visit intake from patients to support them in their visit in the clinical reasoning. So that's one example.
Yes, what I was going to say is, we talked about what AI is good at, right? Like it looks like it learns pretty quickly from pattern recognition, and maybe is better than clinicians at even diagnostic purposes. What is it poor at? I know you mentioned somewhat that it doesn't say I don't know, but so what do you think AI is poor at so far, and how would it get better afterwards with that?
Yeah. So, and again, I just want to reiterate, it's better when compared head to head with human clinicians. It's more accurate at making a diagnosis on clinical vignettes, right? On case vignettes as opposed to real cases. Where it's not good at, there are many things it's not good at. One of them is around recognizing uncertainty. It will recognize uncertainty if it matches a particular pattern in its trained knowledge, as opposed to real, true uncertainty. Another thing where AI is getting better at, but it's not there yet by any means, is multimodal data acquisition, which is, imagine a ChatGPT with a camera and able to see a patient, see the setting, capture information that is not structured, and using that to drive clinical reasoning. That it's not great at yet. I think its performance will probably be improving over the next few years. But until then, relying on AI for anything outside of text is not something that we should do at this point. The other task I find personally, as in my own use, where AI is really, really helpful at, is as a scribe. Having a scribe available when you're seeing a patient, the data is showing that although it does save maybe in 1 or 2 minutes, not more, from each visit, what it's really been helpful at is liberating clinicians from writing or from interacting with the computer and spending more time looking at the patient. In fact, some patients are weirded out. I remember going to see an orthopedic surgeon because of a hand injury, and they were using a scribe during the visit, and I was shocked by the interaction I had. I mean, we were speaking the entire time, and not once did the surgeon write down notes, and was dependent on the scribe. And I've used it on my own, and it's been remarkable. It's been really freed me from having to type a note or write down notes during the encounter. The key thing, though, is it makes mistakes, and think about it as a co-pilot. In all of these tasks, it's there as a co-pilot, and co-pilots make mistakes just like pilots do. And I think it's really important for clinicians to be aware that they can make mistakes so they can catch them in time.
So one thing that came to my mind as we're talking is AI and empathy, let's say. Like, is it able to be empathetic to patients, or to recognize like when patients are anxious or depressed or are holding back from telling a story?
The research, well, like everything, it depends. First of all, what's true empathy? I don't want to go there. If you tell me, does AI have true empathy? I would say no. Does it express empathy? I would say yes. And that's been shown over and over. And that's actually, it's more of a feature than a bug, because these models have been trained by humans giving them feedback, and they're trained to please. That's what we refer to as AI psychophancy. AI is trained to make the user happy. And accordingly, again, because it's been trained on all of human knowledge and also trained by human feedback, it will recognize or attempt to recognize the need of a particular user based on their question, and then answer accordingly. I mean, I'm sure, Khalil, you've tried using it, and it can either apologize or thank you, or sometimes it's annoying. Sometimes it's a bit too nice to me, too empathetic. But the research has shown that it scores highly on empathy scores when it's used by patients or patient actors, for sure.
Interesting. Yeah, I mean, that is very interesting. But this is all, again, we need to recognize that this is patient actors for the most part, but maybe some patients. But a lot of the studies have been done on patient actors.
But I want to highlight the risk here is yes, again, empathy is good, of course. But if AI tries to be too pleasing or too sycophantic, it will agree with you when it should not. And the risk here is around misinformation. So for example, if you ask it once about an association between, let's say, a vaccine and autism, right? So this is an area where there's, rife with misinformation. If you ask it the first time, around 30% of AI models will actually agree with a false fact. The 70% will disagree appropriately. If you ask it a second time, and a third time, and a fourth time, all the models will ultimately cave. And that's because they are designed to cave and are designed to please a particular user. And the research there is evolving, but it's pretty concerning that even the frontier models, even though they're better than some of the smaller models, will cave to misinformation if you ask in a particular way and if you ask it enough.
Right, and it's becoming actually, there's some entities like AI-induced psychosis now because it keeps pleasing the people, and then people tend to become like, have psychotic features because of that, because it keeps pleasing them back and forth.
Yeah.
So we sort of said AI, but a lot of physicians now and experts are referring to it more as augmented intelligence rather than artificial intelligence in healthcare. What does augmented intelligence mean, and why is it a better term maybe than artificial intelligence in the case of healthcare?
Yeah. In a review, I wrote a review article on the use of AI in education, and as I was writing as I was doing research for this paper, I came across several definitions of AI. There's a technical definition of AI, a generative AI, expert models, neural networks, convoluted neural networks, so on and so forth. Again, I'm not a computer scientist, but there are obviously a lot of different technical definitions of AI. There are capability-based definitions of AI. This is an AI scribe. This is a visual AI. This is a knowledge retrieval AI. But then there's a relational definition of AI, which is defining a computer system on how it interacts with a human. And augmented intelligence is a form of defining AI by what it does in relationship to a human. And augmented intelligence refers to computer systems that deliver an output that augments human intelligence. I like that definition because it emphasizes the fact that these tools should be designed and assessed in relationship to the human AI interaction. Its purpose is to augment human intelligence across the board. Sometimes it can augment it more autonomously than less. I've seen papers where they refer to autonomous computer systems that express intelligence as AI, and computer systems that are designed to work with humans as augmented intelligence. I haven't seen that term used that often, but in my mind, augmented intelligence emphasizes the point that these tools are there to support human decision making.
So, yeah, in that case, what are your recommendations for clinicians who are just starting to use these augmented intelligence tools?
Yeah. So first, I want to just be clear. I am not anthropomorphizing AI tools, computer systems, when I call them co-pilots. What I like about defining an AI as a co-pilot, and it could be as a co-clinician, as a co-scientist, as a co-artist, whatever you want, as a co-friend, is that it tells the human that this is a computer system that can deliver insights and judgments that you should be taken seriously. There are things it may be better than you at, and there are things that it's not as good as you at. And so that creates two things. One, it allows us to accept the fact that these tools can be helpful, but it also tells us that we need to be aware that these tools can make mistakes. And I think if we frame our interactions with AI around a pilot-co-pilot interaction, it tells the human that they need to behave like pilots. And if you look at the airline industry, The way that pilots are trained to work in the cockpit, they follow what's called a crew resource management training. In other words, how do you work in a cockpit in a high-stake environment where tools can falter and where you're working with the co-pilot that is there to support you but can also make mistakes? And a key competency there is something called situational awareness. In other words, be aware at all times that an output of an AI can be false. And you can dial that situational awareness up or down depending on the stakes. So for example, if I'm using ChatGPT to write an email, I'm not going to spend, my vigilance is not going to be very, very high. But if I'm using a AI clinical decision support tool like Open Evidence or Heidi or UpToDate's Expert AI, to make a decision for a patient right in front of me, I'm going to really check its answer. So that's my one advice is sort of be aware that AI can be great, but can also be bad. In high-stakes situations, I always tell my colleagues and students and residents that the next best competency that we need to develop when we work with co-pilots is cross-checking. If the need is there, if you're using it to make a high-stake decision, you need to cross-check an answer. And what does cross-checking mean? Cross-checking means, can you confirm a judgment of an AI by asking the AI for confirmation or looking at it in a different source? This is where tools, AI-based clinical decision support tools are useful. So tools like Open Evidence and UpToDate's Expert AI, when they give a judgment, they actually have a citation. And you can actually look at the citation and confirm if the output is correct. Sometimes you can't, and sometimes you actually need to look up a reference or even make a consult. So I think cross-checking is a key competency that we need to develop. And that's why the New England Journal of Medicine was among the first to recognize the importance of grounding AI tools in trusted information. And so we and others have licensing agreements with a lot of these companies to make sure that the answer that they give to clinicians is accurate. So that's why when you use Open Evidence, for example, you'd often see citations from the New England Journal of Medicine along with tables and graphics and stuff like that. That's because these tools are grounded in trusted information. Whereas other tools don't have access to that content, and even though they could be more accurate in some situations, right? Even though an advanced ChatGPT model could be very accurate in making a diagnosis, it's very difficult to cross-check it. And so for me, I find it hard to trust it in a high-stake situation, unless I have research that shows that it's actually it's safe enough and accurate enough to use.
Right, and as you said, I think what we're talking about is AI currently is augmenting physicians' diagnostic capabilities and not replacing them, because we still need to check it. And one thing you said, which is very important, is not all AI tools have access to all these journals or the content of these journals, so it's hard for them to be able to give you the correct answer if they just have access to, let's say, the abstract and not the whole part.
Just to clarify, it's not that they cannot give a correct answer, it's that they cannot attribute an answer to a particular source. And that attribution is really essential to help clinicians trust the particular judgment. The issue of trust is paramount here. When I'm reading an article in the New England Journal of Medicine, or reading UpToDate, or reading Harrison's Principles of Internal Medicine, do I cross-check every reference? Not necessarily, because I trust that the authors, and especially the editors, did that for me, right? Sometimes, I'll check the references, but I've trusted that job has been done by human experts that have my best interest in mind. That's not the case with AI, right? AI intrinsically does not have any incentive to either hurt me or please me. And that creates a trust gap that we need to fill in many different ways. And attributing a judgment or an AI output to a particular citation is really helpful to close that trust gap. So, which is why, again, ChatGPT may give a very accurate answer, but if I cannot attribute it to a particular citation, and especially that older models sometimes gave fake citations, I think is a problem in high-stake situations.
Yeah, I remember, we're not going to talk about this particular situation, but there's been situations where big firms have like released data with like inaccurate citations because they used AI when they did that and they did not cross-check them. Saying that, how do you see the relationship between the human expertise and augmented intelligence in the next decade?
I'm not going to go decade because I have no idea where AI is going to be in 10 years. I have no idea where we're going to be in 10 years. And I think these two questions are related. But I would say that in the next few years, there's going to be a heightened emphasis on expertise. Expertise is going to be required to work effectively with the co-pilot. Think about it. You can't be a pilot if you don't know how to fly a plane alone. Like, what if the co-pilot, I don't know, passes out? And so expertise is going to be even more critical to be working with a co-pilot and to be working with a very effective co-pilot. So you're going to require that expertise to work with them. Similarly, it's going to become less and less justifiable for expert clinicians not to work with AI, especially if and when research starts demonstrating that human experts working with effective AI tools perform better than humans alone. And so what I'm seeing in the future is we're going to be shifting from what we've been taught traditionally, Khalil, which is we graduate from medical school and residency for independent practice. In other words, we should be able to treat patients on our own, to a situation moving forward where expert clinicians will have access to an excellent co-pilot that's going to live in their pocket, and these experts must know when and how to use their co-pilots effectively.
Right, so it's going to augment us, hopefully, and not, because a lot of physicians are scared that it's going to take over our jobs, but it's going to augment us, make us better, but not take over our jobs.
Yeah, I think, listen, there are multiple things to be afraid of. Sure, one of them is, will AI take over our job? But there are other things, is what will AI do to our skills? Will AI make us do worse? Will we learn false information? Are there situations where I need to use AI and I don't know how to, right? There's a lot of different things that we need to be afraid of. And I think one of them is that AI replaces us. But I would argue that is there a scenario where we should be afraid that not choosing an AI is going to be bad? Right. I mean, it's possible. There's a scenario where we could be working with an AI tool that makes us better, and not choosing it would be a mistake. I would talk. The one thing that I'm particularly interested and concerned about is the effect of AI on skills. Listen, I work in an academic hospital, right? I work with some of the best residents and fellows in the country. I have access to the best experts in different specialty areas available. What do you think that does to my own skills, right? So if I'm doing less and less procedures, right, because there's a fellow to supervise a resident and I become much more of a supervisor than an actor, I guarantee you that some of my procedure skills are different than when I was a resident or a fellow, right? So there's this de-skilling that's happening with the use of AI. Now, if I'm a medical student or an intern, and I can ask ChatGPT or Open Evidence or Heidi or whatever to solve a case or to answer a particular problem without the need to do the research on our own, what's that going to do to the clinical reasoning skills of our trainees? I think that's a big problem that we need to think through to avoid a situation where we'll end up with pilots that just aren't equipped to work with co-pilots. That's what I'm concerned about.
Yes, you're sort of concerned about loss of skills or de-skilling, as you said, because of that, and that's what we need to watch for.
Yeah.
Saying that, I'm going to ask you some rapid questions right now. What is one clinical reasoning skill every physician should master?
Communication. Slow down, speak clearly to your patients, make sure they understand. Because you could be the best expert clinicians in the world. If you cannot translate your reasoning or communicate your reasoning to a patient, then it's all for naught.
That is accurate. One cognitive bias every clinician should watch for.
I have two. Actually, I have several. anchoring bias. So where you think you have the right answer and you have information that's coming in that's telling you, no, it's not the right answer. And you're like, no, this is the right answer. So you anchor. The other one is premature closure, where you get information and you say, okay, I have a diagnosis, and then you stop there. Like you don't go and get more and more data. And then the one that I think people under-recognize, but it's all over, it's around us all the time, is diagnostic momentum. Diagnostic momentum is where we're handed off information by the patient, and there's a diagnosis that's carried forward from handoff to handoff, and nobody actually stopped to say, well, wait a second, does this patient really have asthma? Where is that sound? Is it عندك أم عندي?
Yeah, and I was muted actually. So yeah. So, but then I lost your sound for a bit, but it's fine. We can continue. What is one AI misconception you wish would disappear?
Sorry, man, there was an alarm going on. Yeah, diagnostic momentum. What's the other question?
What is one AI misconception you wish would disappear?
What's one AI misconception I wish would disappear?
On this question, man. I got you on this question.
I mean, there's a lot there, but I think it's a good one. A misconception. What are examples of misconceptions, I guess, around AI?
Like people saying, it's going to replace our jobs, or I don't know, let's say it's not empathetic to our patients, or it's never going to have empathy, stuff like that.
Well, I think that, but what I don't want to do is state a misconception I want to disappear, because that would then, I would be acting on my own bias. I'd be closing prematurely or anchoring, because all of these are open questions. So one misconception, though, is that I wish would disappear is one that assumes that AI is correct. The misconception that it sounds so fluent, it speaks like an expert, then they must be correct. And I think that fluency trap is a misconception that I wish needs to disappear. People need to work with AI assuming it's wrong until proven otherwise.
Yeah, so always check it, and that's what people sometimes, because there could be some bias too, because it's very easy. You go in, gives you the answer. You're like, okay, this is the answer. I'm not going to check it out. Let's move on and do something else.
100%, 100%. And listen, we're all victim of not checking or not double checking, because we're tired. We see dozens of patients. We do many things. We're exhausted, and sometimes slowing down to think and cross-checking is the last thing we want to do. And we just need to be cautious that this can happen, and need to be aware that not to let it happen when it matters the most.
Right, and as I move on, I know we're getting close to finishing, but I fell into this trap one time, because I was doing the schedule for our faculty for next year, and I used ChatGPT this time to make the schedule, and then I told it do Mondays, whatever, and then I sent the schedule out eventually without 100% cross-checking it, and then they came back to me. They're like, "Why are you starting our rotations on Wednesdays when we typically start on Mondays?" I'm like, "Oh yeah, let me change it," but.
Yeah, I mean, man, the number of times these things happen, and again, it depends on the stakes. Like if you were doing a schedule for your daughter's, I don't know, like a sports schedule, then okay, you're not going to spend a lot of time. But if this is a schedule for the entire service, then maybe you should have double checked, Khalil. So just be careful next time.
Exactly. And what is one AI tool or application that excites you the most?
AI application.
Yes.
My listen, I love the scribe. I have an accent. You have an accent. The Siri, Alexa, all this stuff, they do a terrible job. The AI scribes right now are just amazing, and I use them all the time. I barely type anymore. I speak out everything on my computer. Prompts, Word documents, emails. There's a lot of AI scribe tools that just specifically do that, and then they polish the thing. It's amazing. That's for me has really changed how I interact with computer systems. Let alone think, because now I have to think out loud. That's the other thing about scribes that we should be. That I think is very interesting from a research perspective is that yes, we're no longer writing notes and. Sure, residents and trainees and medical students may no longer need to write an HNP. What does that do to the clinical reasoning? Conversely, now because they are scribes, they have to think out loud more, right? For the reasoning to go into the note and for the scribe to work well, they need to think out loud. Well, maybe that's even better, because not only do they need to practice how to reason out loud, but it also means that they're communicating their reasoning better to patients, right? So there's a lot of interesting nuances here that are worth exploring. So anyway, I'm very excited about scribes.
Right, because if you're going to doing your assessment and plan, you need to communicate it to the patients so AI
Yeah,
can write it for you.
yeah,
So
yeah.
basically, so will AI replace?
So sorry, Khalid, I need to jump. I have another meeting now.
What is it?
I have another meeting. I need to
Oh yeah,
jump.
yeah. Last question. خلينا نعمل لك last question وخلصنا. If you could give one piece of advice to clinicians navigating the AI revolution, what would it be?
Practice makes perfect. Just practice as many tools as possible. Learn about them, read about them, and then you'll know where it works for you and where it doesn't.
All right, great, Raja. Thanks for being on the podcast, and hopefully people learned about AI and clinical reasoning through
My
this.
pleasure.
Bye. Thank you.
Bye. Take care.